A conundrum has evolved regarding the wisdom of intensive compared with somewhat less intensive control of hyperglycemia. Intensive control is invaluable in preventing microvascular complications of types 1 and 2 diabetes. The incidence and severity of these sequelae are direct consequences of the magnitude and persistence of hyperglycemia. By contrast, macrovascular complications of type 2 diabetes are less directly linked to hyperglycemia per se. They reflect contributions of numerous pathogenetic features, including dyslipidemia with increased VLDL cholesterol and triglycerides, increased free fatty acids, decreased HDL, central obesity, hypertension, decreased hepatic glycogenolysis and gluconeogenesis, and decreased oxidation of free fatty acids in skeletal muscle, with intracellular accumulation of lipids that impair insulin signaling. All of these are associated with insulin resistance. Thus, it's not surprising that maximal reduction of the risk of macrovascular complications and cardiovascular disease requires multiple interventions, including a heart-healthy diet, regular exercise, and pharmacologic management that addresses the panoply of all of these phenomena rather than hyperglycemia alone. In special settings such as intensive care units and coronary care units, intensive glycemic control had been thought to be essential for optimal clinical outcomes. However, recent observations indicate that somewhat less intensive control, with targeted blood glucose of 140 to 180 milligrams per deciliter rather than less than 126, may be safer and more desirable. Patients with type 2 diabetes may have cardiac autonomic neuropathy that impairs the cardiovascular system's capacity to respond to hypoglycemia. In those who do, even modest and brief episodes of hypoglycemia can be extraordinarily deleterious. One factor accounting for a possible long-term advantage of somewhat less intensive glycemic control appears to be the reduction of a risk of hypoglycemia. Results in several large-scale, highly publicized recent trials, including ADVANCE, ACCORD, and VADIT, led to the surprising finding that intensive control was not associated with more favorable long-term outcomes compared with those seen with less intensive control. Although hypoglycemia with consequent adverse effects associated with intensive control has not been proven to account for this finding, many believe that it may be playing a role. A recent study by Zhao et al. Examines the impact of hypoglycemia on vascular risk among veterans with type 2 diabetes. In a large number of studied subjects and matched controls, episodic hypoglycemia associated with the use of anti-hyperglycemic medications was associated also with a substantially higher risk of incident vascular events over prolonged intervals. Taken together, these observations and the considerations mentioned above militate against the wisdom of an exclusive focus on intensive glycemic control to minimize cardiovascular risk. We certainly do not want to return to a laissez-faire approach to glycemic control. However, targeted hemoglobin A1C in the range of 7% rather than to 6.5% or less, and individualized targeted glycemic control tailored to each patient's overall risk, accompanied by vigorous control of all cardiovascular risk factors, may be more beneficial than a laser-like focus on the most intensive glycemic control possible.